For those of you that know me, you know I'm essentially theoretical physiologist with a background in electrical engineering and from MIT. So it's a very unique combination. And over the past 15 years, physicians all the time go, Brian, we love your work, but it's too theoretical. Do you have a machine? Can you give me a number? Can you give me a waveform that shows what you're saying actually works? And for 15 years, the answer's been no. Well, today the answer is yes, and I've never been so excited. This is about pulse wave velocity with digital pulse analysis. And it's non-invasive, easy to use, insurance reimbursable, economical method to assess patients' cardiovascular physiologic status backed by more than 25 years of advanced medical research. And it's called a photoelectric plethysmograph. It looks at volume. Arterial stiffness measured by pulse wave velocity is an accepted, strong, independent predictor of cardiovascular events and mortality. Anesthesiologists are well aware of this, but almost nobody else is. Wave reflection is a subject most physicians are never exposed to. The fallacy that there's a single systolic and single diastolic blood pressure number that's the same throughout the body is absolutely wrong, but most people don't appreciate it. And this was known in 1993. Pulse oximeter, put your finger in, non-invasive, excellent machine, but not used. Very high degree of correlation, repeatability. It's successful in all clinical applications. Diabetics, I'll talk about that in a minute. Men, women, kids, elderly, doesn't matter. Detects early evidence of vascular disease and how your response to the therapy is, the intervention. 2007, the European Society of Hypertension and Society of Cardiology both said this is an accepted measure for the management of arterial hypertension. They're ahead of us. There's been an explosion. Pulse wave velocity established important biophysical marker of arterial aging, independent, highly predictive of cardiovascular outcome. Who here has even heard of pulse wave analysis or digital pulse analysis? Anybody? 1, 2, 3. Not many. Not many. Extremely responsive to therapeutic interventions. 3 to 6 months, you can see differences. It's insurance reimbursable. It's in the office, 5 minutes. Anybody can do it. It's simple. Really great aspect is you get a biological age of the patient where they look at different populations that are known. So a 20-year-old, 30-year-old, 50-year-old, 80-year-old, and you see where the patient fits. The reason most physicians are completely unaware of this is until now there was no successful intervention that increased directly compliance, arterial flexibility, like the last lecture mentioned. Well, there is a study now, it's called Iowa, investigating oils with respect to arterial blockage, and it's plant-based, parent essential oils. For those of you that are familiar with my work, it's parent omega-6 and 3 with a little first derivative of omega-6, that's it. No fish oil derivatives, no EPA, no DHA. And that commenced December of last year, and I'll be telling you about the results of those as measured by this machine. Unfortunately, today's surrogates don't work. LDL-C therapy fails to prevent cardiovascular disease. Ineffective surrogate, the 2008 Jupiter study you've all know about. Stressed C-reactive protein is the surrogate marker. That's the actual mechanism for statins because, as the author of the study stated, half of all myocardial infarctions and strokes occur among healthy men and women with levels of LDL cholesterol below thresholds for treatment. So here you have a surrogate. It's not needed anymore. Even coronary calcium, CA, called into question. These used to be considered the gold standards. Get a CT scan, little radiation, but tells you the calcified calcium in the arterial wall. It's been called into question. C-reactive protein, the supposed mechanism of the Jupiter study and statins, called into question. Now we have a machine that looks at the actual flexibility of the artery with no surrogates. You don't need a surrogate that somebody's telling you works when the studies show they don't, or your offices show they don't. I'm always asking cardiologists, if statins worked, why are your offices so loaded with people? Well, it's an NNT of 100, if you followed my work, meaning a 99% failure rate. I treat 100 patients with a statin, 1 success, 99% failure rate. That's not real good. Aging and decreased arterial flexibility. It's known that aging increases less flexibility of the artery. That's the number one thing. It starts in the aorta, major risk factor in ischemic heart disease, and the pulse wave doubles between 17 and 70. So it's very, very easy to pick up these kind of changes electronically. Aortic stiffness is a very significant issue. The machine gives you an index of stiffness of both the aorta and the large arteries throughout the body. On the left is the elements of the plethysmograph. It starts at number 1, S on the bottom left, goes over to the right, so the first half is diastolic, then it goes, or systolic rather, to diastolic. Left ventricle contracts, goes up to P. T is the influence of the small arteries. Aortic flap closes at C, and you could read about that. The great thing is when you take the second derivative of this is looking at flow over time, okay, and it's reading the blood oxygen level, as the pulse oximeter is with a lot more sophistication. You take the second derivative, want the second derivative because blood pressure variation's gone. Doesn't matter what my blood pressure is with this. So it's really, really great. And the ideal APG is on the right. So what you want, if you look at the right, the indices of it, you want a big distance between A and B, and you want C higher. So what happens, and these are the patterns, a 20-year-old would have virtually an ideal APG. 80-year-old, it goes to there. So B keeps going up, C and D keep going down, and that's how you get the age population. And it's broken down by decade and 3 subdivisions within decade. So it's extremely precise. Again, warning, blood pressure is late-stage diagnostic. It's only a very crude indicator of the arterial wall. Again, blood pressure is not enough, and when they looked at diabetics, the blood pressure was the same between diabetic and non-diabetics, and there was an enormous difference that DPA took up. And I'll tell you about that in a minute. Pharmacologically decreased BP masks cardiovascular problems. A lot of physicians wrongly think that the clinical treatment's effective, but it's merely decreasing blood pressure. It's giving you an illusion. So unlike other surrogates, pulse wave velocity is independent of arterial pressure. I'm excited right now because I'm so excited about this information. I could measure myself. The output would be the same as when I woke up in bed. No other thing will give you that. A regular blood pressure, even central blood pressure machines, and they have those. They aren't good enough. They vary.